These are some things I wish physical therapists knew before treating patients with Ehlers Danlos Syndrome. So Ehlers Danlos Syndrome is a connective tissue disorder that affects all connective tissue in all different parts of the body. I see so many physical therapists that don't know what EDS is or don't know how to treat it. One of the first big problems is that Ehlers Danlos isn't talked about in a lot of different physical therapy programs. My PT school in particular did not mention it once, and I was actually formally diagnosed while I was in PT school, so I pulled professors aside and kind of explained, hey, this is what's going on with me, and things of that nature. Only one or two of them knew what it even was, and several were still practicing physical therapists. So that's one of the biggest problems. A lot of times I will have PTs reach out to me and say, hey, I have a patient with EDS. I don't know what to do. What do you recommend? My first recommendation is if you can find someone that is familiar with it and that treats it consistently and is good at treating it in your area, referring that patient to them. So that's why I've jumped on here and created this, is to try to give PTs a better idea of what you need to do when that person with EDS walks in your door. Piece of information number one is that there are 13 types of Ehlers-Danlos syndrome, and the most common type is the hypermobile type, but not every patient with EDS has hypermobility as a big symptom. Now, a lot of the times patients are going to be coming to you, they're going to have the hypermobile EDS type. Something else that's important to note is that out of those 13 types, there is a genetic marker for 12 of them. And of course, you guessed it, the one type that does not have a genetic marker yet, although there is research happening that they think they may have found something, but the one type that doesn't have a confirmed genetic marker is the hypermobile EDS. The second big thing I want physical therapists to know when they are treating this diagnosis, or when they have someone in their office that is hypermobile, please, please, please stop assuming that just because someone is hypermobile that they have Ehlers-Danlos syndrome. There is so much more that goes into EDS than just having joint hypermobility. Yeah, I'm hypermobile, I hyperextend, there's a lot of ligamentous laxity, but they don't really have any other issues, then you're not going to meet the diagnostic criteria for EDS, which at this point is still a clinical diagnosis made by a geneticist most of the time, but you're not going to meet that criteria if it's just, that's the only thing, is you've got a little bit of joint hypermobility going on. The third thing that I want physical therapists to know when they are treating EDS is please, 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 please be careful when you are trying to stretch your patient. We have this laxity, right? We're getting these joint dislocations, joint subluxations, things like that. The brain kicks on, sends that signal to those surrounding muscles saying that connective tissue is not doing the job. So we need to turn on the muscles, we need to bring everything in so that we can protect the joint and we don't have any more subluxations, dislocations, trauma, anything to this joint. So we get this hypertonicity of the muscle, which, as we know, can lead to pain because we're not able to pump waste effectively. We're not able to get the nutrients to the muscles we need. We get those trigger points that can be so painful because we're not getting the proper contraction and relaxation of the muscle to move well, effectively, efficiently, all those sorts of things. It broke my heart to see people say, oh my gosh, I left physical therapy, I did a lot of stretching, they did a lot of manual therapy on these tight muscles, and I left in more pain, or I had temporary relief, but then my joints started to dislocate and sublux way more, which caused more pain, and so on and so on. When we go and we work out all those knots and what would normally be an appropriate intervention for someone with EDS, it's not appropriate to stretch them and work out all of that muscle tightness, because that tightness is providing this inherent stability to the joint that the connective tissue can't provide. So that's one of the most common mistakes. So think about it, as soon as you do that, you start this whole cycle over again where you're causing more dislocations, more subluxations because more laxity in the joint. So that brain sends that signal, those muscles turn back on again, and it's kind of this never-ending loop. Now, it can be appropriate in certain times, especially if it is pulling a joint out of place, or it's this antagonistic muscle that's putting the wrong pressure on. I mean, there are times that it is appropriate, but I do like to say most of the time it is not the best intervention for you to do. Now, if you want to do a little bit of that and then work that into some more neuro re-ed of getting the muscle to not be in this hypertonic state, but to be able to relax a little bit so it can contract and relax more efficiently and more effectively, then do that, but follow it up with the appropriate interventions of strengthening into that newfound range that you have, and really getting the most bang for your buck, instead of we're just going to give you some manual and send you on your way, because you're going to be doing your patients a disservice most of the time. The fourth thing is to look at the comorbidities. There are a lot of comorbidities of things that are commonly diagnosed with EDS. One of those most common things being POTS, which is a postural orthostatic tachycardia syndrome. So obviously it's that increase in heart rate as this response to positional changes. Now, it is way more than just the tachycardia, and I will do a whole nother video on things that I wish PTs knew, or doctors in general knew, before they treated someone with POTS. But just know that POTS is a common comorbidity. Mast cell activation syndrome is another common comorbidity that is important to notice, especially if you are doing dry needling. If you are needling into these areas of high mast cell content, that patients are going to have a bigger response. You need to take a really thorough history to see what these conditions are. And if you are not familiar with them, either A, ask them directly, or B, mention it, put it to the side, and then go back and look into it after your evaluation so you can kind of see where you need to go and what you need to do, because your patient might not always know that that's going to be something that's going to kind of relate to what you're doing with therapy. The fifth thing, this one's going to be a little more specific to patients with hypermobile EDS, but that is if your patient is having headaches or having any dizziness or anything else along those lines, please check them for craniocervical instability. Chiari malformations are very common in this population, but craniocervical instability is such a huge thing. I had a patient that was diagnosed with EDS that I was treating, that I did a VBI test on her, and turns out instantly she was positive for vertebrobasal artery insufficiency and almost passed out on the spot. I did some very gentle palpation of her cervical spine in supine and started to do some of that upper ligamentous testing, and realized immediately that she had craniocervical instability. And so I talked to her and I said, all right, I want to be very direct with you. Obviously, this is outside of my scope of things that I am allowed to officially diagnose, but this is a big enough thing that we need to talk about it, and we need to talk about it now. And we went and discussed CCI and VBI, and she said, oh my gosh, that explains everything. That explains all my symptoms when I'm driving and checking my blind spots, and why she was having this dizziness. I told her immediately, we need to purchase a C-collar at a local drugstore. She did. I instantly called her primary care physician, who is the referring physician on the case. The PCP got her in the next day, called me, we had a long conversation about it, and she was so thankful that we caught this, because it was something that was very quickly overlooked. Please be aware of that craniocervical instability. It is a huge thing, and headaches are so common. So let's get in there, let's rule it out, and or rule it in and refer when necessary. The sixth thing, don't be afraid to strengthen them. Yes, this is going to have to be another thing where you have to dose very appropriately. You need to start low. If you need to be doing isometrics, things like that, yes, please start there. But strengthen, please. When prior to PT school, prior to my diagnosis, I was a power lifter. Did a lot of weight training and things like that. I had a bunch of physicians, family members, friends, my OT say, why would you do that? You're so accident prone. You've had all these injuries. All you're going to do is get hurt. This was prior to my PT school days, and I kind of was starting to understand the importance and the benefits of exercise. But I then realized after strength training pretty consistently up to a good level, powerlifting, doing some good Olympic lifts, that my dislocations were at an all-time low. That is honestly the best time, the best I have felt. The lowest amount of dislocations and subluxations and chronic pain that I have had was when I was actively lifting heavy consistently. You have to make sure that they are doing them correctly, because as soon as they do something like move too far into hyperextension, or which I don't want them to do anyway, putting excess stress on all of those joints, we have a problem. So getting them with that perfect form. Now, I personally at my clinic do not double book. I am one-on-one for the full 60 minutes for evaluations and for treatments every single day in my outpatient clinic. If you are not able to do one-on-one for every patient, this is the patient you need to be seeing one-on-one 100% of the time, in my own professional opinion. You need to be watching them and critiquing their form for every little thing, because you just want to make sure you're not causing more damage to the joints. Seventh piece of advice is to make those connections. Don't be afraid to reach out to other physical therapists. I see this all the time on Facebook, asking, all right, I'm the only one in my area, or they don't take anyone else but my insurance, or this is a population I'm trying to get into, or anything like that, and you want to know what to do. You're already doing the right thing, watching these videos, reaching out to people, looking out, doing more research of what you should be doing. So keep educating yourself, keep up with the research, make the connections with other physical therapists that treat EDS, refer out when you feel like it's kind of beyond what you should be doing, and just keep doing the best you can for your patients.